Junkins, director of the microbiology department here at Norton Healthcare. He's a member of our Norton Infectious Diseases Institute, and he is going to discuss today the basic for laboratory diagnosis of infectious diseases. And then after this presentation, he's going to go more in detail with each one of the areas. Alan, thank you for participating. Please go ahead.
You're very welcome. Thank you, guys. Yeah, like we said, we want to kind of do a series of presentations on different types of diseases and how we go about diagnosing those. But today is just really just the basics. I wanted to do this first, and I apologize. It is very basic. I apologize if I insult anybody's intelligence, because we're not going to be going too deeply into things here. This is just scratching the surface. But I wanted to do it because, you know, I get the impression a lot of times that a lot of people think this is what the lab is like. You know, you got it's this black hole. And you throw specimens into this black hole, and these answers kind of come out of it. And you don't really have much of an idea of where those answers came from or what we can do to get those answers. Now, it has changed a bit in the past couple of years because laboratory testing has been more in the public eye than ever before. So people tend to know the difference now between antigen testing and molecular testing. But we're going to go over that in a very general sense today. I also want to point out that this title is a little misleading because, as the way I look at it in the laboratory, we don't actually diagnose infectious diseases. The physician or the clinician is in charge of doing that. What we do in the lab is we basically will diagnose infection. We will detect the organism. We will say that there is an organism there, but disease is a different thing. So if you kind of look at it this way, a patient can go anywhere from uninfected, they do not have this organism, all the way to disease. They have this organism and they have symptoms as a result of infection with that organism. And in between, there's a whole range of people who are either colonized with organisms or they are infected, but they're asymptomatic. They're kind of in the middle. And to diagnose the disease, you have to look at a bunch of different things. What the laboratory says, what's the patient presentation, what symptoms are they having, what's their history, have they been exposed, have they traveled, have they eaten bad food or something. And then even take into account the community. What's the likelihood of this given the community? You wouldn't expect to see flu in a normal year. You wouldn't expect to see flu in July. But a patient could show up with those exact same symptoms in January, and you'd be certain that it was flu. So there's more that goes into disease than just the laboratory. This is what I don't want to say we want to see this because this is a diseased patient, but this makes it easy. If you have good evidence here of the patient presentation, patient history, all signs suggest that the patient is diseased, and then the laboratory goes right along with that. This is a pretty easy call to make. But you also get this. The physician is pretty certain that this patient has a certain disease. The presentation looks like it, the history looks like it, but the laboratory doesn't support it whatsoever. That makes it a much harder decision. And we get these too, where the laboratory comes up with some answer that is not at all what anybody was suspecting. You know, this doesn't really fit with the patient presentation. So then that's up to the clinician to decide, is that just a red herring? Is that something different that I didn't really expect? That kind of thing. So we're not really diagnosing infectious diseases here. I've told people a lot over the last couple of years, we do a PCR for SARS-CoV-2. We diagnose SARS-CoV-2 infection or the presence of SARS-CoV-2. That is not necessarily COVID. COVID is the disease. So you have to have the symptoms that go along with that to actually have COVID. That's splitting hairs, but it's kind of the way I look at it. So when it comes to infectious disease in the laboratory, we have two approaches. There is microbiology, where we are going to detect the infectious agent or a certain component or product of the infectious agent. We're looking for the bug. And there's immunology, where you detect the host response to an infectious agent. So we'll go through these tests right here. In microscopy, antigen testing, molecular testing, and culture are the main ways we go about doing that. So I'm a microbiology person, so this is what we do. Here's Lindsay here. She is doing microscopy, reading gram stains. She's looking for the organism. Or microscopy is where you're actually going to go in and you're going to see this organism under the scope. Good things about this is that it can be pretty fast. I mean, some of these things we can do in 30 minutes or an hour or so and get a result back. So it can be fairly quick. The other good thing about it is that it gives you more information. It's not just a positive or negative. You can look at it and you can see what other organisms are there. You get an idea of specimen quality. Was this a well-collected specimen or not? You can look at the white blood cells. Is there evidence of inflammation here? You can look for epithelial cells. Is there evidence of too much contamination here? So you get a good idea of how good a specimen you have from looking under the scope. There are some cons. Cons is that it can be very difficult to interpret. I tell people all the time, looking at direct gram stains directly done on a specimen is the most difficult thing that we do in microbiology. It's a hard thing to do, a hard thing to get right. There's a lot of interpretation that goes into it. Unfortunately, bacteria are very tiny. And so even under a scope, sometimes you're not sure whether you're looking at bacteria or not. It's also pretty limited. We can do a gram stain and we can see we have gram-positive cocci, but I can't tell you which organism that is based upon the gram stain alone. So a lot of times we can't give you identification. It's not fully diagnostic. So some examples of microscopy. The big one that we do all the time here in micro is a direct gram stain. And like I said, we can tell you some information about the specimen, about what organism is in there, but it's typically not diagnostic. Now you can make some suggestions there. You can say something like, well, if you gram stain a spinal fluid and you see lots of white blood cells and you see lots of gram-positive cocci, there's no question. That is diagnostic. That patient's got bacterial meningitis. But if I do a wound specimen and I see gram-positive cocci, I'm not totally certain what that bug is and how important that bug is in causing this. It's going to be very suggestive, but not really give you a diagnosis. Acid-fast stains, same kind of thing. Anatomic pathology, over in our AP section with the pathologists are looking at tissue biopsies. That's often a great test to do. Plus, they can follow it up with specific stains. They can say, this looks like Epstein-Barr infection. So I can stain it with antibodies against Epstein-Barr to show that that's what this is. And we can get much more diagnostic from that. That's kind of combining microscopy and antigen testing together. Sometimes microscopy is the gold standard, the way to do things, especially in parasitology. Like this slide right here, this is the standard way of diagnosing this disease. You look at this and all you have to do, you look at this and say, okay, this patient's got malaria and it is caused by Plasmodium vivax. So we've got pretty much almost everything we need to know just from doing that one smear. So that's microscopy. Let's talk antigen testing, which of course has been all in the news for the last couple of years. So everybody kind of knows what antigen testing is. We are going to detect a structural component of the bug or a product made by the bug. So pros for this approach, it's usually very fast. These tests can be done in 15 minutes up to an hour or so. You can get these done. They're easy to do. No difficulty in setting it up, no difficulty in interpreting it. Some of these are so easy, they're CLIA waived, which means they can be done in a point of care setting. And even some of these can be done at home. I mean, it's not an infectious disease, but people have been doing pregnancy tests for years. It's the same thing as a pregnancy test. So It can be done very easy. SARS, you all now, probably every single one of you got tucked in a drawer in your house, a SARS-CoV-2 antigen test waiting to be done. And they're usually pretty cheap. These things for us, when we buy these, they pretty much range between like $10 to $30 a piece. So they're not really very expensive. But there are cons. Sensitivity is generally not very good. You need to have a well-collected specimen. That's going to be important because sensitivity will not be good. And even when you do have that well-collected specimen, there's going to be a high false negative rate with these for the most part. They are FDA cleared for limited specimen types. I can do microscopy on any specimen that I want. I can do culture on any specimen that I want. I can't do these on any specimen. I can only do these on specimens that the FDA has cleared. For example, if you decide, okay, this might be gross, but let's just say, okay, I've got my home SARS-CoV-2 kit, right? And there's all this story now of people who are shedding it in the GI tract, where they're detecting it in the sewers and everything. I want to test my own stool specimen to see if I've got SARS-CoV-2 in there. No, not allowed to do that. You can do it at home. I can't stop you from doing it, but we can't do it and put it on a patient chart. So they're limited to what has been FDA cleared. And they're targeted to a specific organism. I call it monoqualitative. I kind of made that word up, but you get the idea. It's going to be a plus minus test on a given organism. If it's somebody else, I haven't learned anything. So I have to know specifically what bug I am looking for. Just a warning about these tests. This is something that we say a lot in the laboratory. You've probably heard it as well. Fast, cheap, accurate, pick two. You can have two of those. If you have a test that's fast and cheap, you have to really worry about the accuracy. If you want fast and accurate, well, you can get fast and accurate, but it's not going to be cheap. Okay. So with these, they tend to be fast and cheap. You have to worry about the accuracy. Now, instead of just painting one whole big brush there and blowing off all these antigens, I still don't mean to do that. Some of them are excellent. I was just talking with our pediatric ID group this morning about cryptococcal antigen. And the cryptococcal antigen test is faster and cheaper and more accurate than the cryptococcal PCR test is done. So it can be done. Here's some examples, of course, the SARS-CoV-2 antigen test that looks for the spike glycoprotein. We also do antigen tests for C. difficile toxins. We start with the PCR to detect the bug, and if the PCR is there, then we will look for the toxins, which is very helpful to know the toxin is what causes the disease, after all, not the bug. It's the toxin that causes the disease. So you're actually detecting the thing that causes the toxin. And then there's a couple others, Legionella in urine, Helicobacter in stool. So there's several of these antigen tests that are done in hospital laboratories. Next one is molecular testing, where we're going to detect a specific nucleic acid sequence in the organism, an RNA piece, a piece of RNA or a piece of DNA that's in the organism. So these are your molecular tests, your PCRs for the most part. Generally have very, very good sensitivity. Most of these you're talking about at least 95% sensitive. So if you have it, you're probably going to be positive for the test. They can be fast. Some of these can be done in just 15 minutes now. Some of them may take a few hours. So it can be fast if it's available in-house. Most of your laboratories will have a fairly limited menu of these tests. So if you want to do something that's a little outside that menu, then you may go out to a reference laboratory and take days or a week to get back. Things that are not really very common, for example, most hospital laboratories will not be able to practically bring that in because it won't be a very high volume for it. 10 years ago, these were hard to do. Now the tests that are being done in clinical laboratories are pretty easy to do. This is Danielle over here. She's putting on a rack of COVID PCRs. It's pretty easy for us to do, honestly. I shouldn't say that, but we slide this rack in there and the machine does all the work for us. And there's even some of these now that are being done point of care. We have in our outpatient settings, we have these Roche Liat instruments that will do COVID PCR. We have Cepheid instruments that will do group A strep and flu PCR in point of care setting. The bug does not need to be alive. I'm listing that as a pro in this case. The bug can be dead and you can still detect it. So where that is great news, I'll give you a couple of examples. One is gonorrhea and chlamydia. Both very hard bugs to grow. Gonorrhea dies very quickly when it's outside of a body. So culture is not going to be very sensitive because most of the time when it gets to the laboratory, the bug's going to be dead. This will pick it up. PCR will pick it up, even if it is already dead. Another example would be, we get a lot of children here that have gone to an outside hospital. There's a kid who's in our hospital right now who went to an outside hospital, signs of meningitis. They started immediately treatment with vancomycin and ceftriaxone, sent the kid here. They did a spinal tap here. And we got spinal fluid to culture and to PCR. The culture is not growing. And the culture is not growing because that child was already exposed to vancomycin and ceftriaxone before they collected the specimen. But the PCR is still picking it up. We still know that this kid's got strep pneumo. So the bug doesn't have to be alive. That can be a big advantage. PCRs can be qualitative, plus or minus. It's there or it's not. And they can be quantitative. We do viral loads on HIV and Hep C and some others. So you can kind of get an idea how much of the bug is there. And they can be multiplexed. I'm sure many of you have seen the big panels, respiratory pathogen panels, spinal fluid panel, blood culture panels that can look for 10, 20 bugs at one time. Very helpful, very helpful. But there are cons. They tend to be a little on the pricey side, okay? For the most part, we'll call them fairly early pricey. Even though they're much easier to do now, you still have to be very careful and you have to be very clean. There's always a chance of contamination. Some of these PCRs will detect as little as 6 copies of a virus per milliliter. That's incredibly small amount. So any contamination whatsoever, you can still get false positives with these. Like the antigen tests, they're FDA cleared for very limited specimen types. We've had people that have asked me if we could do the COVID PCR on spinal fluid specimens. And I'd say, no, I'm not really allowed to do that. I can't report those results. Like the antigen testing, it's mono-qualitative unless it's multiplexed. So if you do, for example, a Legionella PCR on a sputum specimen, if it's positive, you got Legionella. If it's negative, you really don't know anything. You haven't learned anything else. There's questions about what a positive means sometimes. Sometimes it's harder to interpret than you think it should be. And the bug doesn't need to be alive. Now, I call that a pro earlier. I'm calling it a negative now because DNA can last a long time. Sometimes what you're detecting is not the organism right here. You're detecting the DNA of the organism, or the RNA over the organism. And that does not necessarily mean that you have intact, viable organism there. I'll go back to gonorrhea and chlamydia. I just 2 minutes ago said that was a great advantage with gonorrhea and chlamydia, that the bug doesn't need to be alive. But it's also a disadvantage because a person can be treated for chlamydia or gonorrhea, and 2, 3, 4 weeks later, you'll still be positive by the PCR because you'll continue to shed virus, well, not virus, but DNA, RNA from these killed non-viable organisms. So you have to keep that into account as well. Here are some examples. SARS-CoV-2, of course, gonorrhea and chlamydia I've talked about. This is a graph here of output from a C. diff PCR that we run. good for hard to grow bacteria too. Bartonella is one that we send out a lot. We don't do it in house. You don't culture Bartonella. We're not going to do that. So let's get to culture. Culture, we're going to grow the bug. Culture is what we do most of the time here in micro. What's so wonderful about it? Gives you the most information than anything else. It's polyqualitative. So you're doing basically positive, negative tests for hundreds of different organisms at one time. You don't have to know that I'm looking for this specific organism. More complete microbial profile. I can tell this is the bug here, and these are other organisms that are in that specimen at the same time. I can get several different bugs growing. So I know what the normal flora looks like. I know what the whole microbial picture of this looks like. And it's typically semi-quantitative. We don't usually give numbers, but we'll say this bug is heavy growth, this bug is scant growth, so we know which one appears to be the most important. And a big thing, additional testing. If you want to do full susceptibility testing, you got to culture it. The molecular means just don't cut it at this point. So you got to have the bug for susceptibility testing. You can also do serogrouping. You can also do genotyping. So if you want to characterize that organism, you're going to have to culture it first. And it is the most specific test. We've always considered it the gold standard. If you grow the organism, then you've got the organism. Not totally true there, because the lab sometimes might make a mistake, but it is the most specific. What's good or bad? The speed might be good. We can grow a lot of bugs overnight. We can grow a lot of bugs in 12 to 18 hours. It would take longer than that sometimes to do PCRs or antigen tests, maybe. So sometimes it's good. Sometimes we go a couple months. If you want an AFB culture, it's going to be a couple months before you have a final negative. The cost can be cheap. Sometimes it's just a couple of plates. But sometimes we get organisms, we have to identify them, we have to do susceptibility testing, and that can bump the price up. Unfortunately, you don't kind of know that ahead of time what you're going to get. So the price may be variable. And it only detects viable bugs. So the same kind of thing. The bug has got to be alive before you're going to culture it. That could be both good and bad. Any pre-treatment affects recoverability, just like this girl that we have right now with the strep pneumo. One dose of vancomycin ceftriaxone, we're unable to grow that bug. That's all it takes sometimes. Bug has got to be kept alive, so you have to have good specimen transport. This is really, really important. You have to get good specimen collection, and that specimen has got to get to the laboratory quickly under the right conditions so that the bugs are still alive. We don't want them growing in there, but we need to have them alive. So one of the advantages of PCR is that specimen transport we really don't care about. The bugs can die on the way, but you'll still be able to detect them. Culture takes a lot of skill. It takes a long time to get good plate readers who can read cultures. They need to know all about microbial epidemiology. They need to know about diseases. So it is much more interpretive than the other ones that we've talked about. You still have to have an idea of what you're looking for, because the physician's going to have to say, you can't just say culture this. We're going to have to say, you have to choose between these. A routine culture, aerobic culture, in anaerobic culture, which in our lab, we always pair with the routine. You can't do anaerobic by itself. There's a fungal culture, there's an AFB culture. And I kind of grayed out here, faded out the viral culture, because viral culture is kind of going away. It's been basically entirely replaced by molecular methods. We don't do it in-house anymore, and we send out very, very few. So a physician is still going to have to look at the patient condition and decide what type of cultures are necessary, which can be difficult. I think a lot of times what happens, especially when they go into surgery and they pick out a specimen, they'll check all the boxes, and we'll do all of them just to be on the safe side. And I do want to point out that even within a culture type, when we do a routine culture over here, we have to look only for the most common and most important pathogens. We don't have the ability to go through and test for every single bug on the face of the earth. There is no set of cultural conditions that will grow all organisms. So, bit of a problem. that's microbiology. If we go to immunology, which is not my thing here, so kind of excuse me for a little bit, you're going to look to detect the immune response to the bug, not it itself. This is the classic graph. I wanted to show this first. When you get exposed to a virus, for example, there's a lag phase, and then you start producing IgM in your serum. IgM typically goes up and then kind of comes down. It does not last very long, but after another bit of a delay, you start making IgG, which goes up and lasts for a longer time. So that's classic. Of course, it differs a little bit from every bug to another. So you can't really say that that's going to be the case with every single organism, but you have certain classic criteria for making a diagnosis. Can be fast. It's good for organisms that don't grow well or are hard to get to. So organisms that we can't culture very well, that we can't do a PCR very well. If the bug is in a spot in the body where it's going to be difficult to sample, then serology might be the best way to do it. It's good for rare organisms because you don't have many people who have antibodies against it. Okay, if we wanted some rare organisms, I'm going to mention Heartland virus here coming up. If we wanted to diagnose Heartland virus, we could use serology because it's not a very common virus. Very few people have really had it. So if you have a positive serologic response to it, then that means something. Unlike, if we tested everybody for herpes antibodies right now, most of us would have it, okay, IgG. You have to interpret what that means. So a lot of times you can rule out infection. If you don't have any antibodies against this bug, then that bug is not what's causing the problem. It might be harder to rule in infection. So the cons are pretty well known. Difficult to distinguish current from past infection sometimes. You have to look at that IgG and IgM and kind of get an idea there if that looks like it's now or does it look like you had it 5 years ago. In some cases, there are cross reactions that make specific diagnosis difficult. A good example would be the rickettsia, Rocky Mountain spotted fever, and diseases such as that. They all kind of cross react with each other. So it's very difficult to say exactly which one you have. Now you're dependent upon the patient's immune response. So you're taking their immune capability into factor as another factor there. Some people just are not capable of responding to certain antigens as well. And for me as a microbiologist, I would put in that the issue that you're not actually showing that the bug is there. You're not actually demonstrating that this is the cause of the infection. You're looking for the response and making some assumptions from that. So here's some example, Epstein-Barr virus. We do a lot of serology for Epstein-Barr, kind of helps. We can look at different antigens and kind of stage the infection that way. This picture here is complement fixation for the dimorphic molds like histoplasma, which is really much more sensitive. And since it's going to take us a month at least to culture that bug, the serology really helps out. West Nile virus. A lot of people will try to do spinal fluid PCR for West Nile virus. It's not a good idea. You just don't do that. By the time a patient has signs of encephalitis, the virus is not in the spinal fluid anymore. So serology remains the main thing for West Nile virus. And I mentioned some rare viruses like Heartland. I want to finish up with just this little bit here because that's basically what we do now. This is what we might be doing in 5, 10, 20 years from now. Next generation sequencing is coming along. We use it for some things. We use it in our laboratory here for some oncogenes and detecting genes in humans. But basically, it's a really cool process. There will come a time fairly soon when we will be able to take a specimen, feed it into a machine that will break up all the DNA and then sequence it and put it all back together. And we will get a printout that will look something like this. So here's a sputum specimen, and that's what we got on it. And then we will have to look at that. It's going to detect all these different organisms. It's going to detect the relative concentrations of them. And, we may get to a point where we just don't have to culture anymore. Great thing about it is that it's hypothesis free. What that means is I don't have to think, could this possibly be a fungus? Could this possibly be an aerobic bacterium? Is this an anaerobic? The physician does not have to think ahead of time about what bug might be causing it because this will pick them all up. If you have a parasite in there, it's going to pick that up. If you have a virus, it's going to pick that up. It's a huge amount of information, so interpretation will be very difficult. It's going to be up to microbiologists to look at those charts, look at those reports, and kind of figure out what is the important organism here. You may have seen this. Some labs are offering it now for specific indications, but it really is not ready for prime time routine use. It's too wieldy, too expensive. But it's amazing how much faster and easier and cheaper this has gotten in the past 10 years. And 10 years from now, it's going to be even faster and easier and cheaper. And we'll have much prettier databases as well. So that is what I wanted to get through. I will be happy to take any questions. Like I said, it was very basic, over the top kind of an overview. And hopefully when we get through the coming up months, we'll be able to hit some topics a little bit more specifically.
Well, thank you very much. It was an excellent overview of the different aspects. And as you mentioned, you're going to get more specific. I want to see, do we have any comments or questions from the audience? Then, Alan, you mentioned that we are using next generation sequencing already. Do we have some practices or some physicians that are using this at Norton Healthcare?
The only testing that we're actually doing here, and it's not in micro, it's in our molecular laboratory, is on human, not looking for microorganisms, but looking for human genes. And it's just barely getting started. As far as infectious diseases, there are some reference laboratories that will do it for specific purposes. And we've had some that have been sent out. There are some urology offices that send it out on urine specifically to look for things like prostatitis. There are orthopedic doctors will send it out on joint fluids because sometimes, joint fluids are difficult to grow a bug from. Bugs don't like to grow from those sometimes. There are some available to do on BAL specimens to look for causes of pneumonia. So they have these that are available out there. And like I said, it's early. It's something, my personal feeling on it is that it's something that you need some interpretation on before it gets sent out to doctors.
Do we have any, Ruth, you tell me this, any comments or questions? One of the, it has been always a challenge that when we want to diagnose tuberculosis, we have a positive VSMR, then microbiology takes weeks to culture the organism. Do you see anything coming in the future that can help us to make a diagnosis of tuberculosis, considering the infection control, infection prevention implications? Do you see anything coming?
Well, we do have the PCR. So there is a PCR available that can be done on respiratory specimens. It's a rapid on-demand PCR, and we do that if a physician orders it, or if we get a positive smear on a respiratory specimen, we'll call the physician up and see if they want it added. A lot of times with those, they know it's going to be Mycobacterium avium, so they're not too concerned with it. But the PCR is a good rapid test just for TB. It doesn't look for other AFB. Beyond that, then we have to get into some other molecular next generation sequencing type stuff that is available. There's a universal AFB.
From the perspective of culturing the organism and obtain the susceptibility, how to best to treat the patient. Now that we have the possibility of resistance, we still have to wait weeks.
You still have to wait. Yeah, there's not really any getting around that. I've seen, excuse me, I've seen one study. Sorry, choking up on it. I've seen one study that was done on doing sequencing of TB, to try to detect resistance genes. And it didn't work very well. It detected only about 50% of the actual phenotypic resistance. So yeah, that is a problem.
Alan, now that the U.S. government has sent COVID tests across the country and everybody has the antigen test at home, you know what is because you said that from the 3 you select 2, and these antigens are cheap and fast, then the accuracy is questionable. How confident do we have? Because we are using all these things and we say, well, everybody's using these kits at home. What would be the false negative? You have to come up with a number. And the other question is, do you think that because sometimes people say, well, these tests are not 100%, should I do a test now and then in 12 hours or tomorrow I repeat the test because I may increase the antigen level? Do you think that it's, you need to have 2 negative tests to come back to work?
Yeah,
what would be your advice regarding these antigen tests that we all have at home?
I would agree. You know, when those tests came out, you know, it was actually written in the insert. The reason they sold them in packs of 2 was because you needed to do it twice, be negative twice before you really considered yourself negative. If you were negative on Monday, then you wait and test yourself again. I believe it was either one of them said 24 to 48 hours, and one of them said like 24 to 36 hours later or something. You test yourself again, and you're not really negative until you've tested yourself twice with a certain amount of time in between. One of the things that I really, you know, I'll be honest with you, I worry about those being out there. First of all, people being able to use them correctly. And I will tell you, I used to teach a lab medicine class to physician assisting students. And one day, for some reason, I got stuck with the urine pregnancy test. And it was amazing that half of them screwed it up the first time they tried to do it. So I'm like, if the general public gets these, you know, make sure you read the instructions thoroughly before you start it, because you don't want to mess it up. But the other big thing is proper specimen collection. The thing about when we talk about the sensitivity of those is those antigen tests, you have to have 1,000 to 10,000 times more virus there before they're going to be positive compared to a molecular test. So the molecular test that we do can detect 30 copies per mil. You're talking about having to have 10,000 copies per mil before those antigen tests will be positive. So if you are early in the course, or if you don't do a very good job of collecting a specimen, it's going to be negative. Now, if somebody is right in the middle of acute symptoms of COVID, they should have a lot of virus there. And if they do a halfway decent job of collecting that specimen, then it should be positive.
Yeah. Very good. Ruth, do we have any other comments or questions?
No additional questions or comments. So we thank everyone for your attention and participation, and we will have the recording up of the session back on the YouTube channel where you can go for any of these sessions, and we'll have those up by the end of the week.
Thank you, Alan. Thank you very much. Excellent presentation.
Thank you.
Thank you. Thank you. Next week, I think we'll be talking about some of the new AMI standards, specifically those dealing with endoscopes and the reprocessing. So a lot of that new controversial information, we'll have that at our next grand rounds.
Thank you.
Thank you very much.